Today, I'm going to talk about another very important, very interesting topic in emergency medicine, that is genitourinary emergencies. This is part one of it, which includes mainly of acute kidney injuries. While in the part two, we'll talk about some of the diseases which involves scrotum, testicles, and ovaries. So let's move on. We'll talk about the anatomy of male and female reproductive system. As you can see in this diagram, the differences between the female and the male genitourinary system. This anatomy is essential to know, especially in males, because of the diseases that occur in the males, especially prostate or prostate hypertrophy. While on the other hand, the anatomy of female is also essential to know the high incidence of urinary tract infections in females because of small urethra. So that's the prime focus of this lecture: acute kidney injuries. Acute kidney injuries is the insult that's been bared by the kidneys due to many reasons, which I explain further, within few hours or within at least 48 hours. What is the prime symptom of acute kidney injury? It's mainly oliguria or anuria. Oliguria is decreased urinary output and anuria is no urinary output. So, acute kidney injuries is divided into three stages: stage 1, stage 2, and stage 3. How would you define stages of acute kidney injuries? As you can see in this slide, stage 1 is there is increase in serum creatinine more than 1.5 to 2-fold and decrease in urinary output. There are two determinants in the staging of acute kidney injuries. First is serum creatinine level, and second is urinary output. In stage 1, there is increase by 1.5, serum creatinine is increased by 1.5 to 2 times fold from the baseline. And this baseline is not the reference value that you take, it's the baseline of the patient. For example, a patient with usual creatinine of 1 present to you with creatinine of 2.5. That means this patient is having an acute kidney injury. On the other determinant, I said, was decreased urinary output, or the calculation of the urinary output, which leads to or helps to evaluate the stages of the acute kidney injury. Decrease in urinary output to 0.5 ml per kg per hour for consecutive 6 hours. This is stage 1. Moving on to stage 2, it's increase in serum creatinine level from more than 2 to 3 folds of the baseline. And baseline again is the patient's baseline, not the baseline or the reference value that you take. Decrease in urinary output, that is 0.5 ml per kg per hour for consecutive 12 hours, is stage 2. While the stage 3 is increase in serum creatinine level by 3 times the baseline, or increase in serum creatinine level to more than or equal to 354 micromole per liter, is also included in stage 3. And the output is less than 0.3 ml per kg per hour for 24 hours, or consecutive anuria for 12 hours. Why is this staging important? Staging is important because to know the value, to know the circumstances the kidney is going through. So, as I mentioned before, acute kidney injury is a vast subject. It's a very big disease, and it is due to many list of diseases which are divided into 3 parts. That is pre-renal. Pre-renal involves the structures that supply the kidney or renal system. It does not involve the renal system itself. It involves the renal arteries and the renal veins. Next is intrarenal, or the things that causes acute kidney injuries, which involve the renal system, which includes glomerulus membrane, interstitium, and tubules. Next is post-renal, which includes the diseases which cause obstruction and impairment in the drainage of the kidneys. So, pre-renal. So, as I classify the causes of acute kidney injuries, there are things that are related to pre-renal, intrarenal, and post-renal. Pre-renal is most common cause of acute kidney injuries. What is the most common cause of acute kidney injuries? It's pre-renal. And what causes pre-renal acute kidney injuries, which involves hypovolemia, most important cause. What happens in hypovolemia? What are the causes of hypovolemia? Dehydration, diarrhea, vomiting, increased diuresis can cause, or hemorrhage can cause hypovolemia, that is decreased blood supply to the kidneys. Next is sepsis. Sepsis, we talked about in sepsis in septic shock, that sepsis is generalized infection of the body organ system. And kidneys are also affected with sepsis. And again, sepsis leads to dehydration and again, acute kidney injuries. Heart failure. Heart failure is also a cause of a pre-renal acute kidney injuries because of decreased blood supply, because of decreased effective pumping of the blood from the heart. What are the other causes of acute kidney injuries? Vascular abnormalities, for example, renal artery stenosis. Sickle cell anemia can cause acute kidney injuries. Moving on to renal, tubular diseases. Tubular diseases are further divided. Tubular diseases can be caused by multiple reasons, multiple diseases. For example, nephrotoxins, which includes drugs. Rhabdomyolysis can cause tubular necrosis. Acute ischemic tubule can cause acute tubular necrosis and hence renal cause of acute kidney injuries. Glomerular diseases mainly comprises of glomerulonephritis, which is further divided into other parts of glomerulonephritis, which is not included in this lecture because of the other things that are very important and dealing with acute kidney injuries. Vascular or interstitial diseases, for example, malignant hypertension, thrombotic thrombocytopenic purpura, sickle cell diseases, autoimmune can cause interstitial diseases. Acute interstitial nephritis is also caused by drugs and NSAIDs. Moving on to post-renal causes. Again, as I mentioned before, post-renal causes are due to the obstruction or impairment of the drainage of the kidney system and the renal system. The supravesical obstruction, it's rarely, but can happen and can cause acute kidney injuries. Urethral obstruction, which might be due to urethral cancer tumors, calculi, inflammatory diseases. While on the other hand, uretero-pelvic or uretrovesical obstruction can cause acute kidney injuries. Intravesical or infravesical obstruction, which includes benign prostatic hypertrophy, prostatic cancer, bladder carcinoma, cervical carcinoma, and much more, which can cause infravesical obstruction, can cause to acute kidney injuries. Why is this important to know the causes of acute kidney injuries? While working in emergency department, as I said, the most common cause of acute kidney injury is pre-renal, and the most important cause of pre-renal acute kidney injury is hypovolemia. What are the causes of hypovolemia? Again, loss of fluid, increased diuresis of fluid, decreased intake of fluid, and hemorrhage, and much more, which leads to hypovolemia. So while working in emergency department, if you notice a patient with acute kidney injury and the likely cause is dehydration, so giving that patient fluid can help you to revert the acute kidney injuries. On the other hand, sepsis itself can cause acute kidney injury. So antibiotics, fluid resuscitation can help revert acute kidney injuries. And meanwhile, heart failure can be reverted as well with diuretics and agents that help to prevent acute kidney injuries. So again, history taking is very important, especially patients with long-standing kidney injuries or long-standing obstruction. You ask the patient for any urinary incontinence, urgency, frequency, increased nocturnal diuresis, especially in males where there's with advanced age there is increased risk of benign prostatic hypertrophy or prostatic carcinoma, which can cause acute kidney injury. What happens is when there's tubules, there's obstruction with in the fluid of the urinary drainage. This leads to back pressure and hydronephrosis of the kidneys, which eventually leads to acute kidney injury. Associated medical conditions, which includes heart diseases, pulmonary diseases, any malignant hypertension or hypertension, diabetics, increased advanced age. These are the cause of acute are associated things which can cause acute kidney injuries. Before moving on, let's talk about some of the risk factors that might lead to acute kidney injury. For example, advanced age more than 65, patients with diabetic or hypertension, previous history of acute kidney injuries can cause acute kidney injuries again. Chronic kidney injury can cause acute kidney injuries. Malignant hypertension can cause acute kidney injuries. Hypertensive emergency, which leads to end organ damage, especially kidneys, heart, and cerebrovascular system, can cause acute kidney injury as well. Drugs the patient has been taking before, for example, NSAIDs or nephrotoxin drugs, aminoglycosides, which can cause acute kidney injuries, and patients with a history of recurrent renal stones, or patient with a history of renal stones which are not being evacuated effectively can cause hydronephrosis and eventually acute kidney injuries. Drugs, again, nephrotoxins, which includes aminoglycosides, acyclovir, sulfonamides. These can cause acute kidney injuries, and penicillin can cause acute kidney injuries as well. On the other hand, the contrast that have been given to radiological studies can cause acute kidney injury. So, moving on to some physical examination in the patients with oliguria and anuria. Again, as I said before, the most common cause is pre-renal, and the most common cause of pre-renal acute kidney injury is hypovolemia. So what do you look in the patient with acute kidney injury? Vital sign first. Signs of hypertension, for example, hypotension and decreased blood pressure, decreased mean arterial blood pressure, tachycardia, that is reflex or compensatory mechanism because of hypovolemia. Signs of dehydration, general examination, which includes signs of volume depletion, tongue, white-coated tongue, dry mucous membrane. Lethargy, coma, altered mental status can cause sunken eyes, are the signs of volume depletion. Signs of cardiac, pulmonary, renal, or hepatic diseases. Cardio includes myocardial infarction, will lead to decreased ejection fraction, especially in patients with anterior wall MI. Patients with decreased ejection fraction eventually leads to decreased cardiac output and eventually decreased blood supply to the kidneys, and again increased risk of acute kidney injury. On the other hand, the pulmonary diseases, which includes pulmonary lung cancer, pulmonary embolism, which leads to massive pulmonary embolism, can lead to decreased blood supply or oxygenated blood supply to the renal system, which eventually leads to acute kidney injuries. Renal diseases, especially patients with chronic renal diseases or patients with diabetic nephropathy, patients with hypertensive emergency, patients with malignant hypertension can cause acute kidney injury. So these are the patients who should be examined and should be examined thoroughly. Patients with hepatic diseases, for example, patient with long-standing hepatitis C, or patient with long-standing liver cirrhosis, or patients with long-standing portal hypertension can cause renal diseases. Long-standing hepatitis C can lead to hepatorenal syndrome, which is hepatitis leading to renal impairment and hence eventually hepatorenal syndrome. Moving on to abdominal examination, look for signs of any renal artery stenosis. That's bruit. You can auscultate with the stethoscope. Look for any signs of dehydration with abdominal examination. Look for signs of any tenderness, any ascites, or any swelling that is abnormal in the patients or patient who present with acute kidney injury. Palpate lower abdomen, suprapubic mass consistent with distended bladder. At times, it happens is when there is increased obstruction of the urinary outflow or impairment of the renal drainage. There is palpable bladder. Palpable bladder is firm, but it's firm, soft, and not hard on palpation. You auscultate, there is dull on percussion if there is increase in fluid accumulation in the urinary bladder. So this is a sign of obstruction. The patient cannot pass the urine because of any obstruction. This obstruction can be due to prostatic hypertrophy. This patient can be having obstruction due to calculi that obstructing of a massive calculi that is obstructing the pathway. How do you check on for the prostate? A simple digital rectal examination can help you identify the prostate if this is enlarged or not. Benign prostatic hypertrophy, prostatic carcinoma can obstruct the pathway or outlet obstruction for the urine, which can lead to a palpable or palpable bladder and eventually hydronephrosis of the kidneys, which leads to acute kidney injury. Genitourinary examination, as I said, digital rectal examination, as you can see in this diagram, this rectum, via rectum, you assess the prostate. The prostate enlargement, if you feel like a stony, hard prostate, think of a prostate cancer. If this is a benign or high-riding prostate, think of a benign prostatic hypertrophy, which can lead to urinary tract obstruction. Knowing the patient is elderly male, there is increased chances of patient with benign prostatic hypertrophy, because with advancing age in the males, there is increased incidence of prostate hypertrophy, which leads to the signs and symptoms of urinary urgency, frequency, low stream or inappropriate stream, urinary incontinence at times, inability to feel the bladder is empty or not. These are the signs of obstruction and benign prostatic hypertrophy. Masses, again, the prostatic mass, if this is stony hard, think of prostatic carcinoma. Prostatic hypertrophy, tenderness in patients with acute prostatitis can lead to tenderness and while digital examination and dislocation, that is high riding of prostate. So, detection of bladder outlet obstruction. Prostatic hypertrophy, again, it's a repetition what we have said, what we had talked about before. Prostatic hypertrophy is, again, there is increased obstruction or obstruction to the outflow of the urine. What happens is there is a prostatic urethra which passes through the prostate gland. With prostate hypertrophy, there is narrowing of the lumen of the urethra, of the prostatic urethra. What happens then is there is increased back pressure or accumulation in the bladder and eventually back to the ureter and eventually back to the kidneys, which increases pressure inside the kidneys and it can cause acute kidney injuries and hypertrophy of the kidneys. Urethral structures and valves strictures can cause acute kidney injuries because of obstruction of the urinary outflow. Bladder stones or tumor. Renal calculi, again, is a common cause of urinary tract obstruction. Let me discuss with you a clinical scenario. I received a young patient who was with no previous comorbidities, presented to me with severe metabolic acidosis. With severe metabolic acidosis, there is decreased urinary output. With the CT scan that he had from outside, that shows a renal calculi of 22 millimeters, and creatinine was of 11.6 in that patient. So what happened is the urinary tract obstruction leads to have acute kidney injuries because of impairment of the drainage of the renal system or the urine. So bladder stones in the tumor, especially the prostatic carcinoma, can stop or can cause the impairment of the renal outflow. Neuropathic bladder, especially in patients with trauma, spinal cord injuries, this can have a neuropathic bladder where there is decrease in impairment in the sphincter muscle contraction or relaxation, which can cause acute kidney injuries and urinary tract outlet obstruction. Traumatic urethral injuries, it's rare, but it happens in the patient with trauma. This can cause urinary tract obstruction and outflow obstruction as well. Before moving on to specific diseases and the treatment that could be given in the emergency department, I would like to spend some time on what are the complications of acute kidney injuries if not treated adequately. What first is metabolic complications, which includes severe metabolic acidosis. That is an indication for dialysis. Next is electrolyte imbalances, for example, hyperkalemia. Hyperkalemia itself is an emergency, which leads to dysarrhythmias. How does it show in EKG? Tall tended T waves. Cardiac, which includes myocardial suppression, fluid overload. Signs of the effect of electrolyte abnormalities, for example, hyperkalemia, which leads to dysarrhythmias. Pulmonary causes that include fluid overload. Hematological, which includes anemia, platelet dysfunction. Next, the CNS neurological complications, which includes uremic encephalopathy, altered mental status, and coma. So, if not treated, if acute kidney injury is not treated adequately, these are the life-threatening complications that can occur, and this patient might need an urgent dialysis in emergency department. So now moving on to prostatic hypertrophy. There are two types of prostatic hypertrophy: benign and carcinomatous. So how does the patient present? There is gradually increased difficulty in voiding, often with abrupt worsening. What happens is the patient complains of increased urinary frequency, and the patient cannot empty the bladder, or feeling of not emptying the bladder after coming out from the toilet. There is increased burning. There can be increased nocturnal diuresis. Patient wakes up a couple of times, many more times at night, just to void. These are the signs of benign or prostatic hypertrophy, and this most commonly in males, especially with advancing age. So enlarged prostate on rectal examination. Why is this so difficult to tackle in emergency department? Because with enlarged prostate, you cannot help the patient to drain the bladder because of the obstruction that is causing the narrowing of the lumen. So if you try to attempt the Foley's catheterization, that is internal catheterization of the urinary bladder to drain out and to relieve the symptoms, because it couldn't be happen because of the prostatic enlargement. So you have to move for a suprapubic or the other measures to drain the bladder. So detection of bladder outlet obstruction, urethral strictures or valves. Again, previous attack of urethritis can cause urethral strictures, especially patients with long-standing or recurrent urinary tract infection, patients who are bedbound, patients who are internally catheterized or passed Foley's catheter for much time, could lead to urethral strictures and valves, and this can cause acute kidney injuries and outlet obstruction. And in these patients also, there is difficulty to pass a Foley's catheter because of the stricture, which if tried for more times can cause bleeding or can cause false tracking in the urinary tract. History of urethral trauma can cause urethral strictures. And what should be done in these patients? Ureterogram and urethroscopy, which help to identify the strictures and to relieve the symptoms which are caused by the urethral strictures. Moving on to bladder stones and tumor. A young patient comes to you with history of flank pain with no urinary symptom. You go for a urine dipstick and you see a hematuria. You order in a CT scan. What do you see? There are likely chances to see a stone in the renal tract system. So renal stone present with acute flank pain, or also there can be this can cause outlet obstruction, because if the stone is massive and obstructing the pathway, this can cause decreased urinary output. So bladder stone, as you can see in this diagram, the greenish structures, the circular structures, show the bladder stones. This can present with hematuria. Again, a patient present with flank pain can cause, on the urine dipstick, can have a hematuria, which is a sign of lower urinary tract obstruction. Urethral catheter is passed without difficulty. Why? Because of no obstruction in the way of a Foley's catheter. So it's easy to pass a Foley's catheter. Why is Foley's catheter so much important? That's been discussed with every diseases, because we have to monitor the output of the patient. If it's adequate, this patient could be sent home, or the patient is stable enough to be sent home. Cystogram and cystoscopy. Again, flexible cystoscopy is widely used nowadays to get into the way of genitourinary tract and to see if there is any obstruction, and to relieve that obstruction, to relieve the symptoms of that patient. Neuropathic bladder. Again, signs of spinal cord injury. Patients with other neuropathic injuries, patients with history of spinal cord trauma can have a neuropathic bladder. Associated neurological abnormalities. Urethral catheter passed without difficulty because, again, of no obstruction in the way of Foley's catheter. Cytometrogram is the diagnostic, or is widely used in patients with neuropathic bladder, and to see what is affecting the output of the renal system. Traumatic urethral injuries, history of trauma, road traffic accident, patients with a fight or any trauma that can cause urethral injuries. Prostatic dislocation can cause bladder arterial obstruction, and urethral bleeding is a sign with urethral trauma. So the important take-home message in traumatic urethral injury is: do not pass the catheter. Why? Because of urethral injuries, there are increased chances if you pass the Foley's catheter. This catheter could form a false tract and can lead to a stricture formation, or the tract can cause an abnormal bleeding in the Foley's catheter and from the site of injury. Retrogram urethrogram is widely used in patients with traumatic urethral injuries. Percutaneous cystogram is also used in patients with traumatic urethral injuries. So, now comes the treatment. When you see a patient and you examine the abdomen, you see a palpable urinary bladder or distended urinary bladder, and the patient is complaining of increased urgency, but he or she could not pass the urine. So what should be done in emergency department? Knowing what we have been talking before, with whom you can pass the Foley's catheter easily, and with whom you cannot pass it, and especially in the patients with prostatic hypertrophy. First and the foremost thing you have to do is you have to relieve the patient's symptoms, irrespective of what might be the cause is. Because in emergency department, you have to treat the patient. You have to treat the symptoms, not the cause of the symptoms. So distended bladder, IV access. Draw blood complete count, electrolytes, blood urea nitrogen, and serum creatinine levels. Why? Before going on to the further details of the treatment, I would like to spend some time on some of the investigations that are required in patients who present with acute genitourinary emergencies. The most importantly widely used is urine dipstick, creatinine, blood urea nitrogen, full blood count, urine CS, and blood CS. Serum osmolality compared with urine osmolality, serum sodium compared with urinary sodium. These are importantly widely used. Why? Because as we described at the start of this lecture about what might be the cause of acute kidney injury, simple test, simple urine osmolality and further things could help you differentiate in the patient and help you to make the diagnosis of the patient what might be the cause of acute kidney injury. For example, patient with serum osmolality is increased as compared to urine osmolality. So what does that mean? That the tubular structures are patent. This might be the cause of acute kidney injury is likely pre-renal. Because why? Because the tubules are functioning properly and can reabsorb the sodium that has to be reabsorbed normally in patent tubules. So the serum osmolality is increased as is increased as compared to urine osmolality. On the other hand, with acute tubular necrosis, the urine osmolality is increased because of decreased sodium reabsorption. So these are the important things you can differentiate in patients with acute kidney injury just with serum or urine osmolality. On the other hand, if serum sodium is increased, think of pre-renal cause. Again, with the same reason, the tubules are working adequately and they can reabsorb the sodium. While on the other hand, if the tubules are affected, there is increased urinary sodium levels. Also, the same happens with urea and creatinine. Increase in urea reabsorption is a sign of patent tubules, but decrease in urea reabsorption is a sign of tubular necrosis. So again, what might be the cause of tubular necrosis? Nephrotoxins. Acute ischemic insult could lead to acute tubular necrosis. So coming back again, draw blood complete count, electrolytes, blood urea nitrogen, and serum creatinine. Serum creatinine, why? Because to stage and to know if the patient is having acute kidney injury and what stage it is on. Electrolyte levels, to see any electrolyte abnormalities that are caused by complicated acute kidney injuries, for example, hyperkalemia. Drain the bladder. How to do that? Drain the bladder with Foley's catheterization or suprapubic, urethral catheter or suprapubic catheter. Suprapubic catheter is a large ball that's inserted 2 finger breadth above the pubic symphysis. It is hard at times for patients with urethral strictures and prostatic hypertrophy to catheterize. So these patients should be referred, or urologists should be on board when these patients, so they can put on a flexible cystoscopy or they can try for suprapubic catheterization. Again, before treating the cause, treat the symptom what the patient is presented with. Bladder is not palpable, patient able to void. Again, draw complete blood count, blood urea nitrogen, serum creatinine levels, urine CS. Send urine specimen for urinalysis and urine culture. Treat cystitis or prostatitis if present. Patient present with fever, urinary symptoms, think of cystitis or prostatitis, or recurrent urinary tract infection can lead to cystitis as well. Blood chemistry normal, refer to urologist. Azotemia or electrolyte abnormalities, severe or long-standing obstructive uropathy, this patient needs urgent urology consultation, or patient might need an urgent dialysis, hospitalization and urgent dialysis if required. What are the indications of patients presenting to you with anuria and signs of acute kidney injuries? Who needs dialysis? Patients with severe metabolic acidosis, increased creatinine levels, hyperkalemia, despite the medical or chemical treatment, should be proceeded for dialysis. So bladder not palpable, patient unable to void. It seems like a partial obstruction. Patient feels like he or she cannot empty the bladder completely. So consider differential diagnosis. What might be the cause of these symptoms? Draw blood complete blood count, serum glucose levels, electrolytes, calcium and phosphorus. Calcium and phosphorus are the things that should be addressed in patients with long-standing chronic kidney diseases, because with long-standing chronic kidney diseases or patients with acute and chronic kidney injury can deteriorate the calcium and phosphorus. Test for renal and hepatic functions, blood urea nitrogen, creatinine levels, hepatic function, liver function test, which might be the cause of hepatorenal syndrome. Obtain chest x-ray and abdominal x-rays and ultrasonography. Why is chest x-ray so much important? Because to see the signs of fluid overload. A simple portable chest x-ray in ED can help you identify the signs of fluid overload on the chest x-ray. Abdominal x-rays and ultrasonography. Ultrasonography is widely used and is commonly used and give you a lot of information in patients with lower urinary tract obstruction or patients with moderate to severe hydronephrosis. So stones could be picked on or renal ultrasound, and it's non-invasive, widely used, and it's adequately informative in patients with patients when bladder is not palpable but unable to void. Ensure adequate hydration. At times, bladder is not palpable, patient is not able to void because of decreased urine. And why is of decreased urine? Because of dehydration. So what this patient needs, this patient needs fluids, and fluids. If this patient 1 to 2 liters of fluids orally or IV, the patient could able to pass urine, and likely cause of decreased urine is fluid loss or dehydration. Adult without obvious volume overload, 1 to 2 liters of fluid orally or intravenously. Observe the patient for 1 to 2 hours. If there is adequate urine output, the patient could be sent home, or the patient, if the patient could be sent home with removal of the Foley's catheterization. If anuria persists, cause likely proximal to bladder, this patient needs bladder catheterization and hospitalization. We'll talk about disposition in detail in the coming section as well. So let's talk about the disposition of the patients with acute kidney injury. While emergency physician, you have to realize what would be the disposition of this patient. So before going on into the details of disposition, there are a few things that one has to notice in a patient who presents to you with acute kidney injury. There should be a risk assessment of patients with acute kidney injury. How do you assess the risk? Staging. All the patients with acute kidney injuries should be consulted with urologist or nephrologist if required. All the patients with acute kidney injuries and needs a nephrologist or specialty treatment, for example, patients with vasculitis, glomerulonephritis, myeloma, rhabdomyolysis, these patients should be consulted and should be given a close follow-up with nephrologist or urologist. Patients with sign and systemic symptoms of anuria or acute kidney injury should be admitted, should be hospitalized. So patients with persistent anuria, despite all the efforts done in emergency department, this patient should be hospitalized and should be given further treatment. Patients patients with normal biochemical studies, or patients with normal lab investigations, and patients whose symptoms have improved, could be sent home with a close follow-up with a urologist or nephrologist. So let me summarize what we have talked about till now. We talked about the genitourinary system emergencies, especially the acute kidney injury. What is the diagnostic criteria for acute kidney injuries in emergency? Increase in serum creatinine levels for more than 26 micromole per liter, or increase in 1.5 to 2-folds from the baseline. Decrease in 25% of the GFR in patients and in children and adults is a sign of acute kidney injury. Decrease in urinary output from 0.5 ml per kg per hour for consecutive 6 hours in adults and 8 hours in children is a sign of acute kidney injury. Again, what are the causes of acute kidney injuries? We talked about 3 main classifications of acute kidney injuries. That is pre-renal, which is the most common cause of acute kidney injury. It's that is renal, which involves the renal systems, renal tubules, and the renal interstitium. Then we talked about the post-renal, which is widely caused by the obstruction. In pre-renal, we talked about hypovolemia. What is the most common cause of pre-renal acute kidney injury? Hypovolemia. Hypovolemia due to fluid loss, decreased fluid intake, increased diuresis of the fluids, and due to drugs or patients with dehydration, vomiting, or diarrhea can cause, or hemorrhage can cause dehydration and eventually acute kidney injuries. Patients with acute myocardial infarction can decrease glomerular blood supply, which leads to acute kidney injury as well. Patients with other vascular diseases, malignant hypertension, can cause end organ damage, and malignant or hypertensive emergency can cause end organ damage, which leads to acute kidney injuries. In renal, we talked about the tubular diseases, which includes acute tubular ischemia, that is acute tubular necrosis. We then talked about what might be the cause of tubular injuries in patients with rhabdomyolysis, nephrotoxins, drugs, for example, NSAIDs and aminoglycosides. We talked about the glomerular diseases, for example, glomerulonephritis. We talked about some of the diseases, vascular diseases, which leads to autoimmune diseases, which leads to renal insufficiency or renal deterioration, which leads to acute kidney injuries. We talked about the post-renal, which includes obstructive uropathy, that is most likely due to a calculi, which is ureteric or bladder calculi, prostatic or cervical cancer carcinomas. Patients with benign prostatic hypertrophy can lead to acute kidney injury. Neuropathic bladder can lead to acute kidney injury as well. Urethral valves or strictures with long-standing recurrent UTI can cause urinary tract obstruction. We then talked about some of the classification of patients with bladder palpable and not able to void, whom should be passed the Foley-Zet catheter. We talked about patients with bladder palpable but able to void, what investigations should be taken from them, and what should be the pre-analysis in patients, and what might be the cause on simple urine analysis compared with serum analysis. We then talk about patients who cannot void and the bladder is not palpable. Think of anuria, or think of patients with dehydration. We then talk about the general treatment principles in patients who are presenting to you with acute renal emergencies. That's all for now. Thank you for watching.